Our next topic will be presented by Dr. Suhail Al Shammari. Dr. Suhail Al Shammari is a consultant neurophysician at Mubarak Kabir Hospital and head department of neurology department in Mubarak Kabir, and he is a professor of neurology at Faculty of Medicine. Dr. Suhail, he will present an interesting topic in neurology about updated and special circumstances in epilepsy. Dr. Suhail, tafadhal.
Thank you very much. I would like to really thank the organizing committee for inviting me for this talk. And I hope you see the substance of the talk is going to appeal to the audience of this Al Jahra Medical Day. We will talk about an important, very common clinical problem you may face actually daily in your clinical experience. Okay, and that's, you see the epilepsies. Okay. All right. So this is the objective of the talk today. I'm going to talk about the most recent definitions and the classification of the epilepsies and the epilepsy syndromes. As well, I'll, you see, describe the semiology of epileptic seizures. And I'll be also talking about how do you approach the patients clinically, how would you investigate them, particularly after the first seizure event, and whether you treat these patients who come with first ever seizures, the investigations we use, and I'll be talking about therapies in general. As you know, you cannot really cover epilepsy in one talk, 20 minutes, but I'll try to give you really a flavor of what is going on with some actually messages to take home. Hopefully it will help you in your practice. So according to the International League Against Epilepsy, there are classifications for both seizures and the epileptic syndromes. And these are based actually in the clinical data or the clinical manifestation characteristics of the patient, as well as based on the EEG, electroencephalography. And of course, you see, these will contribute to the description and the classification of epileptic syndromes. Now, you see, now what is actually the definition of seizure? And this seizure is really the same as epilepsy. Of course, it is not. And in seizure, the patient will have a transient, behavioral, or somatosensory, motor, or visual symptom and signs, which are caused by quite an abnormal, excessive, synchronous neuronal activity within the brain. And these seizures, they could be either provoked, that's induced by certain brain injury, or it could be spontaneous or unprovoked. And some patients actually may have recurrent seizures because you see, epilepsy is really the tendency to have recurrent seizures. But you see, there are patients who have recurrent seizures, but really we don't call them epileptic. So according to actually ILE classification in 2014, epilepsy has been defined in a practical way. And it is either, you see, you have recurrent unprovoked seizures, 2 or more. So one seizure usually is not sufficient. And really the seizures, they should take place within 24 hours. Now, somebody has more than one seizure within 24 hours. Is that epilepsy? According actually to this scheme, it is not. Unless you have a single seizure which has actually a heightened risk of future seizures. Or based on the first seizure, you will make the diagnosis of an epileptic syndrome. So seizure type and epileptic syndromes, they are based on the description of seizure behavior, behavioral disturbance, which is you may or other noticed, or based as well as based in the EEG pattern, and it can be aided by neuroimaging, that's particularly MRI, as well as now genetics are coming into play. As we understand, a lot of mutations causing epileptic seizures. Now, epilepsy is very common, and the prevalence is about 5 to 8 in 1,000, and actually about almost up to 5% of the population, they may experience at least one seizure during their lifetime. And there is actually 2 peaks in the incidence, and that's early in life as well as late in life for different reasons. And most of these seizures, they occur below the age of 20. Now, this is just a depiction to illustrate actually the 2 peaks, and you see them very clearly. And now, for the classification has been also based, you see, people, they will hear idiopathic epilepsy, cryptogenic, and symptomatic. So symptomatic is quite clear. There will be an underlying pathology, while the idiopathic, as most of patients, you don't actually find a cause. While cryptogenic, you think there is a pathological process, but you cannot prove it at this time. Now, what are the generalized seizures? They are familiar to all of you. Absence, atypical absence, myoclonic, clonic, tonic, and tonic-clonic, or grand mal seizures in the old terminology, and the atonic or aesthetic, sometimes they are called akinetic seizures. Now, the partial seizures, they are divided into 2, either simple and complex. And these, they arise from a circumscribed, excitable cortical tissue. And the differentiation between the 2, actually, whether you have a change in awareness or consciousness during the event. And the simple, complex partial seizure, they could actually develop in sequence, and they could actually go into secondary generalization. Now, so generalized tonic-clonic seizure, I think this is the most common, and you are familiar with patients who come with the typical semiology of people with generalized tonic-clonic seizures. You have to be actually careful that the description by, you see, the witness or any attendant, it may not be reliable. And these are usually short-lived. Most generalized seizures, they end within 3 minutes. And so generalized tonic-clonic seizures, and these actually, they could be starting as a secondary generalized with a preceding partial seizure. And the patient may have no recollection, so you may have a problem in classifying the seizure, whether it is focal or generalized. And with the onset, patient will have forced head deviation to one side, which could be called versive movement, or by brief vocalization. They go then into actually the maybe just a very short clonic, mostly goes unnoticed. Then the tonic phase, with contraction of agonist and antagonist at the same time, ending with a decaying clonic phase and a post-ictal state. The patient may be drowsy, confused, and amnestic, and they'll just show you. You see now, we're talking absence seizures, and this is a very common problem, and it may arise actually in childhood or in later on what we call juvenile absence seizures, and these they last for seconds with abrupt onset and termination, and the patient will be actually unresponsive with a blank stare, fluttering eyelids, and there may be a little bit of a decreased tone with you see you could see it just maybe the head will you see come down. They may have brief clonic jerks, and there's really very simple automatism or automatic behavior, not similar to what you see to actually in complex partial seizures. So again, you see these are myoclonic and sudden involuntary brief jerks. Again, a type of generalized epilepsy, which could involve restricted muscle or a group of muscle, and it tends to occur in children and may begin in adolescence, in juvenile myoclonic epilepsy. Now, generalized atonic seizure, and these they present with drop attacks, sudden fall to the ground, and these usually they may accompany you see in children a bad epileptic syndrome with bad prognosis, mental retardation like the Lennox-Gastaut syndrome, and we come to partial seizures, and these they are the most common in adults, and they have quite a variety of manifestation which can involve neural functions like motor, sensory, perceptual, and behavioral. And simple partial seizure actually, it may be arising when it is motor in the motor cortex with forced deviation of the head to one side. There may be speech arrest or vocalization, and there may be a stereotype limb or facial movement. The Jacksonian marsh is quite, you see, familiar to you, and it starts maybe in a thumb, in one hand, and then involve the whole arm, and it may actually march to the leg as well as the face, and it could be followed by just a transient weakness, and that's maybe sometimes the history of seizure was not there. It may be confused with a stroke actually, because they have a transient weakness, so be careful about this point. Now the sensory, different really hallucinatory experience, which it could be visual, auditory, it could be somesthetic, like tingling and numbness, olfactory, gustatory, vertigo rarely can be a manifestation of focal seizure, and you see the epigastric sensation of rising, that's abdominal sensation like nausea or sense of sickness, that's maybe just a temporal lobe aura. Now when the auras arise from the primary sensory cortex, they are unformed and primitive, while when it arises from the mesial temporal lobe or association, it is more panoramic, more actually detailed. Now also you can have psychic manifestation, and very familiar with a déjà vu, which is a sensation of visual familiarity, or déjà vu intendo, which is the same actually, but in the auditory context, and the jamais vu, which is a sense of unfamiliarity. You could have a dreamlike or sense of watching themselves, like otoscopy and depersonalization. So psychic really, fear, very important, and religious, ecstasy, and false thinking. Complex partial seizure, we said it is associated with altered consciousness, and when it arises from the temporal lobe, it is simple, lip smacking, chewing, swallowing, grasping, or fumbling with a cloth. When it is frontal, it could be bizarre with bicycling, pelvic thrusting. Now, I would have shown you actually a very bizarre frontal lobe seizure here, which can be misdiagnosed as a pseudo-seizure or psychological non-epileptic seizures. Now, epileptic syndromes, just an example to tell you what I mean. I'll give you two examples, a bad syndrome and a good syndrome. This is the bad, Lennox-Gastaut, and it is primarily seen in children with multiple seizure types, atonic, static, or atypical absence with a prolonged unresponsiveness and complex automatism, as well as generalized tonic-clonic seizures. They have a spike and wave, slow usually discharge, they have impaired cognition, and usually they have abnormal MRI with CNS pathology. Now, this is the good syndrome, which is the juvenile myoclonic epilepsy of Jan's, which is in effect actually it represents about 3 to 11%. It affects individuals between 6 and 22 years, and it is characterized, very characteristic. Ask the patient, just an awakening when you get up in the morning, do you have any twitches? You see students, do they really drop, their pen at school, for example? And this will be associated or followed after a flurry of these by generalized tonic-clonic seizures, and about half of them, they will have abscess seizures as well. So these are called a primary generalized epilepsy, and these actually the differential diagnosis of epilepsy. So syncope is very important.
Sorry, you have 2 minutes, please.
2 minutes, okay. So I think we have to rush. The time is quite limited. What you see in syncope, I'll just show you here in this actually detailed slide. In syncope, they will have frequent lightheadedness and dizziness, and falling with eye closure. The eye closed, they may have actually some just jerks when they fall. They have no, significant post-ictal phenomenon. Migraine, actually, they will have headache after that, and the march is slow, while in transient ischemic attack, it is usually rapid sensory march, and often negative, while in migraine, the symptoms are positive. That's an important thing, and cataplexies just fall after emotional screen. This is just, again, the same thing, and, very important, age, sex, social history, past medical history, psychiatric history, if there is alcohol or drug abuse, and or other drugs, actually, prescription drugs like, for example, tricyclic antidepressants. And the family history is significant. History, lab, neuroimaging, and EEG is very important in assessing these patients. The history of the attack, very important to have actually the duration of the attack. You ask about any injury, tongue biting, incontinence, or any triggers. Also, take a history from a witness, because the patient may not give you the history. And laboratory test, the usual chemistry and hemogram, toxicology screening may need to do it. And don't forget therapeutic drug levels in epileptic patient. If you are suspecting acute symptomatic seizures and maybe CNS infection, you need to do an LP. The EEG, just remember it is positive on only 50% of the patient, and it could be positive in people without epilepsy. It may help you to classify the seizures. And this is just to show you a seizure focus in the top, actually, over there. This is an ictal phenomenon. This is you will see a spike over there, and that's just temporal lobe epilepsy. And here you see just in photic stimulation, we get a photomyoclonic response. And this is actually a patient with pseudo-seizures. And what you see in the top, all this bizarre discharges muscle artifact. And you see after the seizure, or this pseudo-seizure, the EEG goes back to normal right away. And just to show you neuroimaging, this is actually bottom of the sulcus dysplasia, you see, which is a cause of intractable epilepsy. These patients may go for surgery. And showing you here just what is called transmental sign, cortical dysplasia. You see it in a flare. It is just around the mental. And that's, again, surgical. So the treatment, really, I mean, we don't have time, unfortunately. But you see, just you have to select EED according to the specific characteristics of the patient. Use monotherapy. If necessary, we need polytherapy when there is no surgical indication, and add the anti-epileptic drug slowly. Go slow to maximum tolerated dose, and consider changing timing. If dose is to reduce toxicity, for example, sedation, you could give it in the evening. And be careful about the pharmacokinetics, especially with Veritone. You have to really adjust that. And also be careful about interaction, especially Dibecane with Lamictal.
Excuse me, we have to stop.
Okay, I will stop here. And really, I would like to thank the, the organizing committee and the audience. Thank you very much.
Now we have a panel discussion for 5 minutes. I may ask Dr. Suhail Al Shammari to come on stage with Dr. Ali Sahu. We have 5 minutes only for questions. So anybody have a question, he has to raise his hand.
Available in Kuwait. The question is about using plasma light as the preferred or the crystalloid of choice. And the evidence so far suggests that probably plasma light is superior to normal saline in terms of acute kidney injury, mortality, acidosis, coagulopathy, and better than the buffered solution, the other buffered solution in terms of alkalosis. However, it's expensive. And the outcome, the mortality outcome studies are not there that showed solid mortality. There are 2 studies that are ongoing. One of them is probably going to be released later this year. Hopefully will shed some light. But yes, it is a very good alternative, but the cost is prohibitive.
Dr. Ali.
Any other question?
From your presentation, I understood that you prefer to, for patients who need aggressive fluid resuscitation, to give a low colloid fluid as a ring lactate instead of giving him normal saline.
No, okay. For aggressive, if the patient needs a lot of fluids, you may consider using colloids as part of it to reduce the amount of fluid. But the first, the best choice is crystalloids. And balanced crystalloids are better than normal saline. No, but right now, the guidelines have not yet come out, but they were saying crystalloids better than colloids. Use colloids only when you are in non-septic, non-liver patients. Use colloids only when you need aggressive volume resuscitation to reduce the amount of fluid. That's number 1. Number 2, balanced crystalloids are better than they should be the first choice. The third point that I did not mention here, there are some people saying in those patients with shock, septic, hypovolemic, or whatever, yes, there is fluid deficiency, but you also need to use inotropes early on to reduce this massive infusion fluids. I hope I answered that question. Does that answer your question? No, that's what I'm saying. Balanced crystalloids means ringers, lactated ringers. The balanced crystalloids are preferred to normosaline. So yes, ringers lactate.
Yes, my question, Dr. Suhail. As we know that there's no strict guidelines regarding treatment of symptomatic epilepsy, or what we call unprovoked seizure, mainly during encephalopathy, electrolyte, or post-stroke. I want your experience about, since no strict guidelines, what you advise especially is common and in our practice.
Thank you very much, Doctor, for this very important question. Actually, it is in my slides, and really I urge, all, the attendants, they are going to get the slides to look after that. Actually, I think this is very important. Thank you for giving me the chance to really clarify this point. You see, now, people with acute symptomatic seizures, for example, people who have, a seizure secondary to acute stroke, or a CNS infection, encephalitis, or traumatic brain injury, versus people who have actually, symptomatic seizures, but you see these are remote. I think we have shown in a graph that these people, they have a lower risk, you see, compared to those people who had remote symptomatic cerebrovascular disease, for example, or traumatic brain injury. So most people actually, those reactive seizures which you are alluding to, we don't consider them epilepsy. So, and most of them, if you correct really the triggering factor, whether it is an electrolyte abnormality or and organ dysfunction, these people, they recover. And actually, most commonly, you see people with alcohol withdrawal seizures. And whether, you treat these people or not, most of the time, they don't need a treatment. And they will be, you see, cured if they don't have, they don't continue their behavior. But you see, the risk is quite high with those people who have remote symptomatic you see, seizures. And these people, most of them, actually, they may have recurrent seizures in the future. I have also, actually, in the first seizure, the people with first seizure coming, you see, would you treat them or not? Most of these patients, actually, we don't treat them unless they have risk factors for heightened seizures in the future. And these patients who have abnormal MRI, abnormal brain function, or they have abnormal EEG, or they have an epileptic syndrome with a high risk. So these people, we treat them after the first seizure.
Thank you. Thank you.
I'd like to thank Dr. Suhail Al Shammari and Dr. Ali Sahu, and also the chairpersons, Dr. Abdulrahman Al Shammari and Dr. Luqman Hatem. I may ask the head of organizing committee مع المحافظة لتقديم الشهادات تذكارية للدكتور علي السهو والدكتور سهيل الشمري. Now for the second session, may I invite Dr. Adil Abdelhami, Dr. Rida Hilal, Dr. Muhsin Nasr as a chairpersons to present their speakers.